Hello, friends. Welcome back to my channel. First of all, thank you for your support and for subscribing to my channel. If you are new to this channel, I cover topics related to obs and gynae, and I come with a new topic every week. So please subscribe. Today's topic is gestational trophoblastic disease. I will be covering molar and partial and complete mole pregnancy. And then in the next presentation, probably I will cover invasive mole and choriocarcinoma. So let's begin. First of all, what is gestational trophoblastic disease? It's a group of rare diseases in which abnormal trophoblast cells grow inside the uterus after conception, and it gives a classical bunch of grapes appearance or snowstorm appearance. It's not very common. The incidence is roughly between 1 in 714 pregnancies. When it comes to the classification, it has been divided in two groups. One is the pre-malignant conditions, and the second one is the malignant conditions. So the pre-malignant conditions include complete mole and partial mole, while the malignant conditions include invasive mole, placental site trophoblastic tumors, epithelioid trophoblastic tumors, and choriocarcinoma. What is partial mole? So partial molar pregnancies are usually triploid in origin. They normally what happens is two sperms fertilize with an ovum and they makes a zygote. It can be different combination. It can be 69XXX chromosome. It can be 69XXY chromosome, or it can be 69XYY chromosome. In partial molar pregnancy, you do see fetal tissue or fetal blood cells. While in complete mole, what happens is a single sperm either fertilized with empty ovum and they go under the chromosome duplication and forms a zygote of 46XX. And or the two sperms they fertilize with empty ovum and they form either 46XX or 46XY zygote. And in complete mole, you normally don't see any fetal tissue. When it comes to the signs and symptoms, mainly they do present with excessive vaginal bleeding, positive pregnancy test, and then ultrasonic evidence of either classical bunch of grapes appearance or snowstorm appearance. They may be suffering with hyperemesis, excessive uterine enlargement, and very rarely, if they may present with hemoptysis or seizures due to metastatic disease affecting the lungs and brain, but it's very rarely. When it comes to the diagnosis, of course, you do take a history, you send them for the ultrasound, but the definitive diagnosis will be on the histological examination, especially if we haven't seen any fetal tissue during this pregnancy. So it's very important to send the product of conception to lab for histology examination and also to rule out any cancer. So the management is surgical evac is a method of choice for complete and partial molar pregnancies. The best thing is to do it under ultrasound guided. So, and it should be a senior person. What ultrasound will help to take all the products and also reduces the risks of perforation. When it comes to the NTD, it is recommended if patient is suffering with partial molar pregnancy. Oxytocin infusion is not advisable if before the surgical evac, but if we're doing after surgical evac, if patient is bleeding heavily, then it should be a discussion and consider the risk and benefit of starting oxytocin. There's mainly the risk of tissue embolization, but the senior consultant or senior doctor can decide. And as I said, the tissues, it's important to send the tissue for histology to rule out any trophoblastic neoplasia. When it comes to the follow-up, so it's very, very important to talk to the patient and emphasize the importance of follow-up. So the follow-up depend on beta HCG. Sorry about the spelling mistake here. So beta HCG, if it reverts to normal within 56 days of surgical evac, then we just need to follow them up for 6 months from the day of surgical evac. If HCG does not go back to normal within 56 days, then we follow up them for 6 months from the day of normalization of beta HCG, and this is for the complete mole. While in the case of partial mole, we need to have two beta HCG normal reading on separate occasion, at least 4 weeks apart. When it comes to the frequency of testing, so normally we do for first beta ICG 48 hours after surgical evac, and then we do it fortnightly beta ICG level. And after normalization, we just do monthly urine pregnancy test, and we just do it for 6 months depending on the normalization of beta ICG. So this is the follow-up. Any molar pregnancy, complete mole, partial mole, twin pregnancy with complete or partial molar pregnancy, PSTT, ETT, atypical PSN, and so all of these pregnancies, they need to be registered with the gestational trophoblastic diseases center, and then they can arrange the follow-up, and then they can talk about the future pregnancies as well. When it comes to the contraception, so it's important to let them know not to conceive until the follow-up is completed. So depending if it's partial mole, so you need to have two beta ICG reading, normal reading 4 weeks apart, or if it's complete mole, so you have to follow them up 6 months, depending on the beta ICG level. So it's important to tell them to use the contraceptions. So you can have so normally the gestational trophoblastic disease center, they do follow them up and they talk to them about this in detail. And if they had chemotherapy for the neoplasia, then we advise them to avoid pregnancy for 1 year. So yes, this was just a brief presentation about gestational trophoblastic disease. If you have any question, please write in the section, in the comment section. I'll be back with a new topic next week. Hope you have a nice week. Until then, bye.